I'd like to welcome you to our session today on Compassionate Care Continuum, addressing ageism and ableism in pediatric palliative care and palliative care in long-term care. Before we get into our presentation, I would like to take this opportunity to acknowledge that the land on which I am presenting, the city of Gatineau, is the traditional unceded territory of the Algonquin Anishinaabe people. I acknowledge the historical oppression of lands, cultures, and the original peoples in what we now know as Canada, and we are grateful to have the opportunity to be present in this territory. Briefly, a little bit about the Palliative Care ECHO Project. It is a 5-year national initiative to cultivate communities of practice and establish continuous professional development among healthcare providers across Canada who care for patients with life-limiting illness and their families. We encourage you to check out our website at echopalliative.com. The ECHO Project is supported by a financial contribution from Health Canada. Therefore, the views expressed here do not necessarily represent the views of Health Canada. Many of you might know Pallium for our LEAP programs, particularly the LEAP Core course is an interprofessional course that focuses on the essential competencies to provide a palliative care approach. It is, of course, taught by local experts, can be delivered online or in person, and is accredited with both the CCFP and the Royal College. You are more than encouraged to check out our website to get more information about LEAP Core. A few welcome and reminders. So for introductions, and I do see the chat is moving along. Thank you so much for introducing yourselves. Let us know where you're from, your profession. We'd love to hear from you, and feel free to discuss amongst yourselves as well. That's what you're here for. For questions, please use the Q&A function, and we will address questions as they trickle in. Of course, and the session is being recorded and will be emailed to registrants within the next week or so. And remember not to disclose any personal health information during the session. I will now briefly go over the disclosures. So as mentioned, we are partially funded by Health Canada. Pallium is also a non-for-profit organization. And we also generate funds to support operations and research and development from our Pallium pocketbook and the sale of our course registration fees. I myself, along with our two presenters today, do not have anything disclosed, as you can see on the slide in front of you. And of course, the presenters that are present with us today had complete and independent control over the development of the content that you see in front of you, that you will see in front of you today. So just to introduce myself, my name is Diana Vince. I'm the Palliative Care ECHO Project Manager here at Pallium. I will just pass it on to our presenters to allow them to introduce themselves.
All right, so I'll go first. I'm Dr. Amit Arya. I'm a palliative care physician and I work in the Toronto area. I have two major roles. Clinically, I'm the medical director of the Specialist Palliative Care and Long-Term Care Outreach Team at Kensington Health, located in downtown Toronto. And I also work as a palliative care physician at Northwark General Hospital and have faculty appointments at the University of Toronto and at McMaster University.
And my name is Stephanie Van Zanten, and I am one of the physicians with the Pediatric Palliative Care team in Ottawa. So I work at the Children's Hospital of Eastern Ontario and our pediatric hospice called Roger Nielsen House here, which is where I'm presenting from today. And I am an assistant professor at the University of Ottawa.
Thank you to both. Thank you to both, and we're thrilled to have both of you with us today. So briefly, some of the session learning objectives is to gain increased understanding of how ageism and ableism impact the practice of palliative care, to appreciate how our long-term care system, by its very design and history, is ableist, and to understand how our healthcare system discriminates against children and families with disabilities. So now, without further ado, I will pass it along to Dr. Arya.
Thank you so much, Diana. Both Dr. Van Zanten and myself are definitely looking forward to speaking about this topic today. And we will start by just acknowledging that yesterday, it was actually the International Day of Persons with Disabilities. And the theme of this year's day was that what was called United in Action to Rescue and Achieve the Sustainable Development Goals for, with, and by persons with disabilities. So just wanted to recognize that to start off our talk, that yesterday was the International Day of Persons with Disabilities. And then we also wanted to start by kind of having some more disclosures. Really, this is around the fact that, we don't really represent the disabled community, to be very honest. And it's very important that any real and future discussions on this topic should be centered around the voices of disabled people themselves, and especially older adults as well, who are living with disability, young children who are living with a disability, young adults with a disability. That's actually very, very important. But we are going to try to humbly share with you some of the learnings that we have been honored to receive from people who are, disability justice scholars, working with, of course, with patients who are living with a disability, family members who are supporting disabled people. So this is really what we want to do. And we hope that today's talk will be more of an introduction and will sort of just lead to further conversation, among our communities and, opportunities for further learning. The other thing is that, of course, as you might imagine, we're presenting 4 very broad topics in themselves and trying to explain the intersection of them. So this is going to go pretty fast. The 4 topics: ageism, ableism, palliative care and long-term care, and pediatric palliative care. So we're going to try to do our best to try to explain the intersection between all of these 4 different topics. And then the other thing I wanted to add is that, of course, both Dr. Van Zanten and I practice in Ontario. So you may see some aspects of what we speak about and what we discuss really with that Ontario focus, unfortunately. But, much of the data and, much of the things that we do talk about, of course, will have national and perhaps even international, impact and implications, hopefully. Moving on to the next slide. So we'll talk briefly in the beginning of our talk about some definitions around ableism, ageism, and their intersection. So what is ableism? You can see the definition up on your screen: the discrimination of and social prejudice against people with disabilities based on the belief that typical abilities are superior. And I will tell you, I obtained this definition from the Disability Justice Network of Ontario, where I've been honored to learn, a lot about disability justice, ableism, and, once again, that's something I hope to continue to do in the future. And ableism is based on this inherent assumption as well that disabled people are in some way inferior. They require fixing. In some ways, they require separation, away from society for their protection. And it sort of classifies people who are living with a disability as less than, and includes stereotypes. It might include interpersonal forms of discrimination, which might be between a healthcare worker and a patient. But it can also lead to systems developments, which also perpetuate, ongoing discrimination. And that could be historical, and that could also be something ongoing in the present day. And we have to remember that the world was not built with people with disabilities in mind. And because of that, the world we live in, including the healthcare system that we work in, is inherently ableist. And we'll get a little bit into that. Ageism. Ageism refers to stereotypes in terms of how we think, how we feel, prejudice, and how we act towards others or oneself based on age. And I will share with you that, of course, for a majority of people, when they hear ageism, they think about discrimination against older adults. And that is something which I'm going to speak about, but we will shortly hear from Dr. Van Zanten about her perspective on this scenario. But, of course, there's a lot of literature and a lot of, different perspectives on how ageism, affects healthcare for older adults. And I'm going to talk about that. One thing we can think about is about how there's a lot of things around anti-aging medicines, anti-aging, face creams or things to make you look younger. That's kind of, it makes it seem as if, getting older is a harmful scenario to be in, and is not a scenario that any of us would want to be in. There's also this sort of term that we often see, when we're, talking about seniors care, called healthy aging, which often implies that maybe there's an unhealthy aging, and there's people who have failed to thrive, so to say. So a lot of even the language that we use in our healthcare system and amongst ourselves as healthcare professionals is in itself ageist. And I will share, of course, that there is data that shows that at least 1/3 of older Canadians, sometimes more for people who are racialized or people who are immigrants to Canada, do feel that they experience discrimination, based on their age and based on the fact that they're older.
Yeah, and I wanted to touch on the idea of ageism in pediatrics, because exactly like Dr. Arya was saying, we think of an elderly person, but we do see ageism in pediatrics. And what we do in pediatric palliative care is we counsel families across from the time of sort of diagnosis all the way to, transition to adulthood in some cases, but that includes families who may receive a diagnosis of a life-limiting illness during pregnancy, or who may either choose to continue that pregnancy, may choose to end that pregnancy, or have a perinatal loss that occurs very short, either during or very shortly after the time of birth. And there is a culture a little bit in healthcare and in society, actually, where sometimes the language we use, the way in which we counsel, or our expectations of what we expect for grief in the face of a loss, of a perinatal loss, or a life that was much shorter, is not valued in the same way, or there's this expectation it should be, and these are not my words, but sort of easier to get over because it's a shorter life, or they only lived for a long time, and a short period of time, and that the literature shows us that that's just not the case. These are a loss, regardless of age, length of life, is a really transformative, unbelievably difficult experience for families. And we hear in bereavement and in the literature that really validating the life of a child or an infant, no matter how long or short, is extremely important and central to that concept of personhood and themselves as parents. And so I think that we are working to create advocacy in this area and to bring awareness, but we have a long way to go still. And that, this is shown in the literature through in all these different populations, including families who experience an unexpected stillbirth, that there's this idea that it's okay, you can have another baby. This is not validating to the experience and the value of the life just because their age was much smaller and the length of their life was much shorter. So this is something that is a really important, and we don't often think of it when we first think of ageism, but we do see it in practice, unfortunately, in pediatric palliative care as well.
Right, thank you. So how are ageism and ableism both linked? So once again, from the perspective of older adults, well, the reason is because you're more likely to live with a disability as you get older. So as we can see, this data is from Statistics Canada, and it tells us that, the prevalence of disability is 13% for people who are aged 15 to 24 years, but this increases to almost 50% for those aged 75 and over. And a reminder to everyone who's sort of joining us for today's discussion, actually baby boomers, our largest age demographic, turned 75 in 2021. And we know that with that, more and more people are going to be living with a disability. More and more people are going to require access to very important and essential healthcare services in the community, including palliative care. So that's something, of course, we're going to get to as well.
And when we look at on the pediatric side, actually, we have a lot of advances in technology and our ability to provide life-saving and life-sustaining interventions for much smaller and younger infants. And when we look, for example, in the extreme, in the neonatology population, that with decreasing gestational age, the risk for a moderate to severe neurodevelopmental disability increases. So at 25 weeks gestation, a baby's born has about a 24% risk of a moderate to severe neurodevelopmental disability. And as you go backwards in time to 22 weeks, that risk increases to 43%. And so that, big differences in risk and babies who are being who are able to be supported through the NICU starting much younger. And we see this in the population of children who are coming through the pediatric world now. The other intersection that I think is really important in terms of ageism and ableism in pediatrics is the involvement of the kids themselves in decision making, in discussions, because there can be a tendency to make assumptions based on age or assumed ability in terms of their capacity to consent or assent with medical decision making. And so that's something that's always really important for us to be really aware of, to make sure that the voices of those individuals are sought out and able to be heard.
Right, absolutely. And one last point I'll add for this slide, just because it speaks about ageism and ableism, is that we've really seen actually a lot of worsening ageism and ableism with the COVID-19 pandemic. And, you know, a lot of language which speaks about this, where, you know, of course, from the perspective of older adults, the vast majority of people who have experienced the most dire consequences from COVID-19, which is death, are actually were and continue to be older adults. Very close to 90% of actually deaths in Canada are for seniors from COVID-19. And the majority of these people lived with comorbidities, and we've seen language in the media and in the public space around this where people will say something, and sometimes even politicians and public health officials have said things like, well, they were older anyways, you know, they had multiple comorbidities, as if their lives were not worth living and it was okay for them to die. So actually the COVID-19 pandemic has been a glaring example for all of us to learn from, and about how it's very important for us to all combat ageism and ableism. Moving on to the next slide, just wanted to acknowledge, of course, that ageism and ableism are not the only two forms of discrimination that one can experience. And even if someone is experiencing both ageism and ableism, their individual experience can vary greatly, depending on their race, ethnicity, the language they speak, you know, depending on their income, you know, other aspects of socioeconomic status, their sexual orientation, their location. Right. So if they live in a rural area or an urban area, of course, that can impact their access to healthcare services and the provision of healthcare services as well, such as palliative care. So this is a question for us to ask, because often when we think of palliative care, we think of probably some things like, you know, thinking about advanced care planning, symptom management, psychosocial support for families. We think about goals of care discussions. Those are probably things that broadly apply to both my practice as well as Dr. Van Zanten's practice. But how often do you think about the impact of ageism and ableism on your patients? Is this something that you think about when you're delivering that frontline patient care? For those of you who are in leadership roles or administrative roles, perhaps at the meso level or the organizational level, or maybe there might be some people on this call who might have a greater impact and might be working with governments or policymakers or had that opportunity. Is this something you think about? And we really feel that it is important, obviously, to think about these things when we're advocating, and even at the level of providing individual care to patients. So just wanted to raise this question, because often from what we see, palliative care providers don't really think about this. And specifically around ableism, I will remind everyone who's listening today that essentially everyone we are caring for, probably, if not, you know, almost always has some form of disability, right? And we will start talking about this. So the next section of this talk, I'm going to start talking about, you know, ageism and ableism in the long-term care sector, and specifically around elder care as well. And my focus will be less on interpersonal ageism or ableism, which means it's going to be less on perhaps an interaction between a healthcare worker and a patient and family, but more about the system and how the system is not really designed in a way that appropriately supports disabled older adults. So here's the story I want to present. This is not, of course, a real life story, but it's been put together based on many, many life stories that I have, you know, seen through my clinical practice. So Mary is a 95-year-old lady who was admitted to a long-term care home. And the previous history prior to arriving in long-term care is that she had a fall, and she needed to be admitted to hospital after that fall. She was living with probably moderately advanced dementia with her husband. Both her and her husband did not have any children. And unfortunately, nobody really asked why she had the fall. But when I saw her, she told me, or her husband, sorry, told me that the reason she fell is because he was trying to help her to get to the bathroom. They were waiting for a PSW to come through home care, but unfortunately, that PSW never showed up and never arrived. So she had a fall, and then she didn't recover functionally, could not return back home, and then was sent to a long-term care home. In the long-term care home, she's observed to have behaviors, and some of those behaviors involve her repeatedly asking to go home. She's often asking for her husband as well, and she's hoping that he's always coming. When the staff try to call the husband and ask where he is, he unfortunately has multiple medical issues himself. He's in pain, he's not doing well, and it's very, very hard for him to visit her, which creates a barrier to care and leads to ongoing social isolation for Mary. And then, she's prescribed some antipsychotics to help with the behaviors, but unfortunately, these do not help with her restlessness and agitation. And, a few months after arriving in long-term care, she develops a fever. And with the fever, it's hard to get a hold of the husband. Once again, it's been hard to have advanced care planning conversations with the husband. But unfortunately, because, the staff are not really sure what to do, and, this hasn't really been well discussed with the husband, then, Mary ends up in the emergency department. She ends up delirious and ends up on restraints. So this is kind of a sad story, which is repeating itself in many of our long-term care homes and many of our emergency rooms. Of course, we will add, and I will definitely start by saying this is not the experience of everyone in long-term care. So there are definitely some long-term care homes which provide amazing care. There are definitely some emergency rooms which provide amazing care to older adults, but this is sort of, a generalization based on many of the gaps and flaws which continue to exist in our healthcare system. So moving on, specifically looking at older adults and ageism, why have we ended up in this place where, our healthcare systems, particularly those that are meant to support older adults in the community, long-term care and home care, are so underfunded? Well, part of the reason is that when we look at comparator countries, such as the Nordic countries, Canada actually spends a lot less on this sector of healthcare compared to those countries. So, for example, we can think of those countries spending around 3% of their GDP on long-term care and home care services combined. And Canada, this is data from a few years ago, only spends around 1.3%. So we are grossly underspending in terms of in terms of providing healthcare for older adults. And then the second problem is that the proportion of the funding which we do spend goes mostly towards long-term care institutions, buildings, rather than providing people home care. So that's actually a big problem. And it is actually very different, once again, in the Nordic countries and European countries as well. And many people think of Denmark as the gold standard. So in Denmark, around 2/3 of the spending actually goes towards home care and only 1/3 towards long-term care. In fact, in Denmark, they actually have a legislated ban on building any new long-term care homes for the last decade. And, something we'll talk about, spending money in the right way actually leads to a better functioning healthcare system. So they don't have as much crowding in the emergency rooms, and they don't have an alternate level of care crisis or an ALC crisis like we have here in Canada, where there's literally thousands of people who are in hospital waiting for a bed in long-term care. So unfortunately, because of these problems in Canada, we have a culture of institutionalization. There's often an expectation that when people get older and they develop an illness like dementia, frailty, or they get weaker, especially with non-cancer illnesses, there's really no other place to care for these individuals often other than in long-term care, unless somebody has the income to afford, a private caregiver. And just sharing a personal anecdote, I had a colleague who recently was looking after his elderly father at home and also his mother, and they both required 24-hour care, and he was paying about $100,000 a year along with his siblings to support his parents at home. Obviously, we can recognize not everybody can afford $100,000 a year. In fact, many people, or the majority of people, can't. And then they are left in the situation where essentially it's often a coercive choice, where home care has failed and not enough options are available to someone. And then there's no choice but to end up in a long-term care home. And that fundamentally is something that Canada, unfortunately, does all too well. And it's something that we have to recognize as part of the ableist culture of healthcare in which we work in. Just a little bit about the cost impact of this. It's actually a lot more expensive to provide care to older adults in this way, because you have, first of all, capital expenditure. You have to find land, you have to build these expensive buildings, and then you have to obviously pay for utilities. But when people are receiving care in their own homes, you don't have to pay any of that. So you're actually saving money and would be able to care for more people if we just fund home care more. This is not to say that, there are not people who do not benefit at all from ending up in a congregate care setting. But the argument is that even if you do end up in a long-term care home or a congregate care setting, it needs to be less warehouse-like, where we have hundreds of people living together under the same roof, and perhaps more small group homes, or homes that are tailored to people's culture, language, food, and other individual needs, to make sure that people are really living the lives that they actually deserve. One more stat about the economic impact of this disproportionate and incorrect way of spending the money is that in Canada, and this is statistics from the CMA, the Canadian Medical Association, an average person receiving home care in Canada receives about 5 hours of home care per week. And even if we increase that to around 20 hours, we would still be spending less money than caring for them in a long-term care home. So actually, we have a lot more money that we can spend in home care, and we should be spending less in long-term care as well. Now, what are the problems with institutionalization? I kind of sort of hinted at this, but basically it's kind of warehousing seniors. And I was just thinking about recently, there's a hospital in the GTA where they now have 2 new long-term care homes right outside their property. And I'm sure they're going to try their best to provide excellent care. But each one of those long-term care homes has a little over 300 people who are going to be admitted there. So in total, it's 600 beds. So we can imagine, I mean, it's going to be very hard to meet people's individual care needs, their preferences, and this is not really around necessarily medical wishes, but also, how they want to live their lives, because this is supposed to be their home. It's not a healthcare setting, or it's not an acute care setting. This is where they'll be literally living out the rest of their life. So how they're going to meet their food preferences, cultural, religious preferences, all of these things are going to be harder. Congregation by itself, I would argue, is very unnatural. There's no sort of law that says that whenever people get to their 80s or 90s and they experience frailty or dementia, they all have to be housed under the same roof together with each other. In fact, that kind of makes no sense. And then often people, once again, end up being dislocated from familiar settings like their own home, their own family, and their own community. So these are things that are very, very important for us to recognize as we continue to work in a system, especially the long-term care system. And fundamentally, what is happening in a lot of our jurisdictions here in Canada is that policymakers are trying to build their way out of the elder care crisis. And I will say that this is simply impossible. I mean, here in Ontario, the Ontario government has devoted $6.4 billion to redeveloping old long-term care beds and building a whole bunch of new ones. But yet the Auditor General is reporting that in 7 or 8 years, there's going to be an even worse shortage of long-term care beds. So we really need policymakers who can look at the bigger picture here and not just look at long-term care in isolation and continue to do more of the same. That's not what we need. And then, of course, when people arrive in long-term care, the care that they received, ironically, may or may not be that good. So there's a lot of variability between long-term care homes in terms of the care they provide. There's some that are quite good, and then there's some that are providing, of course, a much poorer quality of care. Much of this is related to labor issues, where long-term care homes have chronic staffing shortages even now. So I can tell with you, when I go into long-term care homes, I generally see one nurse looking after about 30 patients, sometimes 25 if we're lucky. And then at night, that goes to about one nurse looking after 50 or 60 patients. So there's obviously problems there. The other thing that is an issue is that, there's this tension between staffing shortages and hiring people as quickly as you can, and then also making sure that they're well trained and they actually are educated in, the specialized care that people in long-term care need, geriatrics and palliative care, and that's often lacking. And of course, that would lead to burnout, and it would lead to high turnover of staff. And then there's, of course, other issues here. There could be a whole talk based on this slide around, the dangers of for-profit delivery of long-term care, but I'm not going to get into that today. But essentially, it should suffice to say that the system is not designed well when it comes to provision of long-term care. And I'm seeing some comments in the chat, which I'll just quickly read out. Thank you so much. So Danusia is saying there's too many policies about safety. Yeah, so thank you for saying that, that are not focused on quality of life. So that's kind of the issue. As I said, long-term care homes are supposed to be people's homes. People are supposed to be allowed to live the lives that they want to, but I literally have patients where they cannot do that. So for example, there are rules in Ontario long-term care homes where people are not really allowed to eat alone. In case they aspirate, there's like a fear that they could. So then somebody has to be there supervising them or watching them. And the same is true with showering. Even if they have the ability to do it themselves, they're not allowed to do it because of these concerns. I had a patient the other day in long-term care who wasn't allowed to keep their hearing aid at the bedside because there's sort of a rule that, or some type of regulation that, the staff have to keep, all these assistive devices. And that's obviously a problem. So yeah, that's a great point. Thank you for bringing that up. And also, Michaela is talking about staff turnover, shared rooms, and, the other issue is around sharing space with a stranger. So obviously, I can tell you most people would not want to do that, would not want to live in like a dorm room, type setting for, their last years of life. Maybe for some people it's better, right? Because there are people who are socially isolated and they would benefit from being around company. And I do see people becoming friends actually when they live in long-term care together, but most people would not want that. And then, of course, being able to get the appropriate care and the care that you deserve in long-term care is very important. So long-term care is framed historically around seniors' care, but actually long-term care is essentially a palliative care space. So for 100% of people, it's their last home prior to death. The median life expectancy in long-term care, at least in Ontario, is 18 months. Across the country, it's 2 years. And the annual mortality rate is 27 to 52.3%. So there are long-term care homes where, literally over 50% of the population actually dies every year. And the average, I would say, in terms of what I've seen, is around a quarter of people. But yet, this is not a service which is guaranteed in long-term care. 81% of long-term care residents actually had no record of palliative care in their last year of life, and that's actually the statistics from the Canadian Institute of Health Information. This is improved from 5 years ago, when it was 94% of residents who had no record of palliative care in their last year of life. And when they're coding palliative care, the problem is they're often thinking about end-of-life care. They're not thinking about those advanced care planning discussions, early integration of symptom management. All of this is also very, very important. So once again, very important that we think about palliative care in long-term care. The other thing is that complexity and acuity is on the rise in long-term care as the population ages. So people are arriving in long-term care who are older, who have more and more comorbidities. Often they have comorbidities like frailty, or so they have underlying illnesses like frailty or dementia. They're more likely to have severe physical impairments as well. And once again, shorter life expectancies. So with that, staffing levels, educational levels and competencies have not improved to that degree in long-term care as they should. So we would think that there should be more availability of specialist services. And I will say that does not include just palliative care, probably includes geriatrics, internal medicine, geriatric psychiatry, but definitely palliative care should be a core skill set in long-term care. And then for residents where extra support is needed, they should be able to see a palliative care specialist. But yet we know from data, only 1 in 8 long-term care residents were able to see a palliative care specialist in their last year of life. We don't have information about where the palliative care specialists were seeing the long-term care resident. It might be even in the emergency room or in acute care when that resident was transferred, because we know in Canada, the most common way that you are sort of connected to palliative care is often not in the community, and often even not in a setting like long-term care, but rather in acute care, which is a problem, right? And that obviously doesn't make any sense. So of course, we need more specialist services. And of course, we need to reframe how we think about long-term care homes in general. I mean, if we think about just the words, people are not living long-term as much in long-term care. The care is kind of lacking. And sadly, many of them don't look like homes either. So at the very least, we need to bring up palliative care in long-term care. And we need to think about how, we need to shift away from that healthy aging model, rather to thinking about a palliative approach, which, as we know, is focused not on dying, but on living well and improving quality of life. And I'm seeing lots of interesting comments coming in the chat. Thank you so much. So I'll just speak about some of these comments very briefly before I hand it over to Dr. Van Zanten. Michaela said many people under age 50, not just elders. That's very true. So there is a significant population of people in long-term care who are younger, people who live with chronic disabilities who may have 10 or 15 years of life left or even more. And of course, we know that the palliative care approach should not be determined based on prognosis, but should be based on need. Paul Vandenbroek has said religious and cultural groups create small care homes to care for their own seniors. They're unfortunately one of the few successful long-term care structures that provide high quality care. So I absolutely agree. Thanks so much for pointing out. And I would just add that, we need more funding for those, religious or cultural specific long-term care homes. In Ontario, only 8% of long-term care homes are are specific to specific cultures or ethnicities. And they often have the longest waiting list. So they're very, very hard to get into. So we need more funding to understand this issue and to make sure that people who are racialized, don't speak English as a first language, also get appropriate care in congregate settings. And then, Therese has also said an issue that I was speaking about, that there's a lot of complexity and sort of mixture of mental health, palliative, developmental channels, seniors, and the staff are not specialized in all areas. And really, there's so much complexity in long-term care, and that's very, very true. So lots of other comments, but I don't want to take up too much time. We'll try to address whatever we can. Thanks so much for keeping things up in the chat, and I will hand it over to my colleague, Dr. Van Zanten.
All right, thanks guys. So we're going to switch gears a little bit and talk a little bit from the pediatric palliative care perspective. So we'll just go to the next slide, please. Awesome. So I am not going to do all of pediatric palliative care justice in this one slide, but just because we tend to be such a subspecialized area and not everyone may be familiar with sort of our model of care and how we practice, I'm going to very briefly talk about pediatric palliative care and a few of the differences between the adult palliative care practices. So we often tend to get involved earlier in closer to the time of diagnosis or earlier in the course of disease, because we don't have the same volume, thankfully, as exists in the adult world. We have this is data from Connect Place in BC, but it is reflective similarly in to our population here, and I think across Canada. We have a much higher percentage compared to our adult colleagues of children or individuals who have their underlying life-limiting or progressive diseases related to neurologic conditions, whether that's rare genetic syndromes, neurodegenerative conditions, metabolic, or chromosomal abnormality that result in a different clinical picture. We have a much smaller percentage of patients who have cancer. And so you see that sort of reflected in the population that we look after. We do end-of-life care, as you all do, symptom management, transitions, and through which I'll talk about in another slide, but also a core component of what we do when we're able to, is to provide respite for those patients who are followed by pediatric palliative care teams, if we have a hospice or an equivalent setting where we are able to provide respite care to these children and families. And that's a really important point that I will refer to in one of my upcoming slides. Next slide, please. So I'm going to talk about Travis. Travis is not the real name of this patient. And this Travis is a patient who, close to his sort of in his preteen years, developed a very severe autoimmune encephalitis. And as a result of this, had very significant permanent neurologic changes. From his baseline, he had severe refractory epilepsy, multiple seizures a day, despite a variety of anti-epileptics, G-tube, intermittent oxygen need, like tons of bone fragility, chronic subluxation of the hips, spinal abnormalities, constipation, reflux, a whole host of medical complexity. And so I just want you to sort of think of Travis as I'm talking through the next couple slides, because I think that there is a lot that I have and continue to learn from him, and that we can all learn from patients like Travis. I'm also just going to highlight it that I think that this picture is from a children's book that was given to my child when he was starting school and taught, and I was really pleased to see, that we're starting to see sometimes differences in he's 4 and he was given a book about a kid in the classroom who is in a wheelchair, has a G-tube. So I think that, this just shows that we need to start a lot younger, and it starts from when they're really little. So my 4-year-old knows what a G-tube is. And I think that's really important. Next slide. Sorry, that was a side tangent. So I think in general, disability-based discrimination is understudied in children. And so this is an area of continued growth where we need to pay more attention, and there's lots to learn and a lot of improvements to be made. In our pediatric palliative care population, we see a lot of what we sort of call children with medical complexity. And they are a subset of the population of children with disabilities, but they are sort of the proportion of the population that I'm going to focus on a bit here today. The difficulty with this CMC discussion is that there's no true consensus around what the definition of it is, but essentially, there's, generally agreed upon, these are children who often have multiple organ systems that are affected by their condition or side effects from treatments of their conditions, tend to have lots of different specialist teams involved. They may have sometimes significant technology dependence or increasing additions of technology, whether that's G-tubes, BiPAP, ventilation at home, that are added to their sort of problem list, should we say. And they are children who have frequent interactions with the healthcare systems, outpatient appointments, tend to have higher frequency of admissions, and they tend to last longer because of their complexity, lots of technology, polypharmacy, lots of issues that just make their care more complex. And to the point where we have subspecialty in pediatrics, the complex care programs dedicated specifically to this population because their needs are so specific, and they need a different approach. And I think the other thing to acknowledge is when we look at the complexity in pediatrics over time, it's really a continuum. Things that used to be, when we looked sort of 20 years ago, things that were, higher complexity are things that we now treat as outpatients in medical day units, for example. And so our technology has changed over time, so the complexity is increasing. And so that is evolving, but we definitely have more kids who fall into this category. Next slide. So when we talk about, Dr. Arya was talking a lot about systems level problems, and I think that is absolutely true in pediatrics too, and we'll touch on some of that. But there was a study that came out this year that I think is really important that did sort of qualitative interviews of families who have children with medical complexity who have experienced discrimination, and sort of created this conceptual model for sort of a framework of the disability-based discrimination in healthcare. And so some of this is individual factors, but sort of feeds into our need and sort of system levels problems. So when they looked at sort of perceived drivers of discrimination from clinicians, things that were identified from families was this sort of lack of knowledge. So, the complexity resulting in not being sure how to proceed with next steps. And this is the perception of families, but there's also studies that do show that clinicians themselves report lack of knowledge and skills and comfort in caring for children and adults with disabilities. And so this is a sort of a gap that really needs to be addressed and not forgotten. And then we also know that there were families who experienced clinician apathy. So really that they just had the feeling that it was felt that their child was not being worthy of the same care as other children. And then a lot of assumptions, and this I'll touch about in a minute, but assumptions about the diagnosis and the quality of life of that child based on what the clinician sees. And that I think is a really, really, really important point. And that sort of this manifests in discrimination in different ways for these families. So, if we're talking about sort of like lack of accessibility, simple things, they seem simple, but, space for wheelchairs to mobilize, scales in offices so children can be weighed. We talk about growth. It's drilled into us. Weight, growth, like as you age, really important, but are there scales where we can weigh the children that we're looking after? Parking, availability of accessible parking, stairs, ramps. Are we creating an environment that welcomes all so that we can provide the best healthcare possible for our patients? And so they think there's a lot of work to be done there. And also in how we communicate. Are we providing communication? So we think of things like language differences. Is there a medical interpreter? But many children communicate in different ways, especially when they have disabilities. And so they may rely on non-verbal forms of communication or use augmented communication devices. So are we actually communicating in the best way that we can to be able to make sure their voices are heard? And how there's a, when there was a theme of dehumanization, so lack of acknowledgement of the patient themselves or how we're communicating with them, which is a bit what I just mentioned. And, substandard patient care. So what they talked about was how we present treatment options or what the next steps are may heavily be influenced by what we think of as quality of life or value. And I think that is a really sort of key thing that underlies a lot of perceptions and misperceptions around disability. Next slide, please. So, really, disability is a social model. There's tons of systemic barriers. I talked about some of these: language interpreters, sign language, and these systemic barriers are really constitute an ableist society that disables disabled people and keeps them, in a place where there's ongoing discrimination. And we, as a society, are not optimizing our ability to have these patients and their families have the best care and all the tools they need in order to be their best. So big issues that we see in pediatric palliative care, these children, these families with medical complexity, they really need a lot of care coordination in a different way. And that requires sort of psychosocial needs, financial support for families, in-home support, like not just the medical needs, but the social, that child within their family context and in their environment. How do we wrap around these families to give them the best care possible? Is our system, in the way it's executed right now, doing that? To which the answer is no. When we talk about supports, Dr. Arya talked about supports in the home for the elderly or older adults with disabilities. That's true with children too. There are not enough community nurses to support families who have children with medical complexities. So, there's discussions, a child receives a tracheostomy, they go home on a trach event, and they're told that you have to have 24 hours eyes on, but there's no additional support in order for that to realistically be provided in the home, unless they can afford to have, pay for private care or have like super enormous social or family support circles. So there's lots of disparities in the supports and transitions. Transitions are hugely problematic. Transitions from hospital to home and transitions from pediatric care to adult care. Like there are huge gaps for these children with medical complexity. We say we need to start this process at age 12. That's what our toolkits say. And because it's such a complicated process, and we just are not, our system is not, created in a way where this is streamlined or allows this to happen in the best way that it possibly could. And there are like entire conferences and talks dedicated to each of these individual topics. Go to the next slide, please. I think it's important to just touch on this idea of the disability paradox. So what this is talking about is that clinicians often predict quality of life to be poor for patients with disability as compared to the patient or parent reported quality of life, which they may say is good or excellent. And so this is a really significant implicit bias against disability because of predictions or perceptions of what a quality of life is. So I think that this is a really important because how we counsel as healthcare providers, we're sort of providing expert advice. We're the clinicians, and we are there for really important serious illness conversations, goals of care discussions. Should we institute new technology for a family? And our perceptions of what a good quality of life influences how those are presented and also how decisions are made. And so I think that we just need to be really cognizant of this idea. One of the questions that I like to ask families is I say, or patients when they're able to participate is, what does a good quality of life mean to you? Because I can't answer that question. We might all answer the question differently. But when we're counseling, it's important to sort of keep this in mind, because technology can be painted in a way where, this piece of technology is really going to be really helpful, can be painted in a really positive light without, enough of the realism of the difficulties and bumps that come along the way. Or, a child who's got, cerebral palsy, repeated admissions for aspiration pneumonia, may really benefit from a G-tube, even though it's a new piece of technology. So there are sort of pros and cons, and I think that this is really, really important in how we provide counseling and care to families. And there, are we the best messengers of this message? Maybe we should be doing more family matching with other families who are living a similar lived experience. So I think there's just a lot of there's a lot here, and we could talk about this particular point for a long time, but I just think it's really important to know that there is a mismatch between perceptions of healthcare providers of quality of life and families themselves, patients and families themselves. I think the one thing that we are uniquely poised to be able to do is in pediatric palliative care, in practices where we are able to provide respite care in a hospice, for example, we are able to see children when they're well. So these children can come in, we're providing respite to their families, they come in, they participate in baking, they do art, they go trick-or-treating, they do all these different things and are, living a good quality of life. But you may not understand that whole aspect of a patient or a family if you only see them when they come into the ICU for another respiratory illness. So I think that this is a really important, thing, is that to remember that we are only seeing snapshots in time sometimes, and this may sort of influence our perceptions when the reality might be really, really different in the home environment or in a more, a less institutional environment. Next slide. So coming back to Travis, Travis, so as you remember, refractory epilepsy, G-tube, oxygen, lots of like bone fragility issues. Travis is an unbelievably smart child teen actually. But if you just looked at Travis, there are assumptions made that he's not able to communicate, that he would be developmentally delayed. Travis has a really specific way of communicating with yes or no, non-verbally. But if someone takes the time to learn how Travis communicates, he likes to direct all his care. He likes to participate in all discussions around even the smallest medication changes. He can eat orally, although you may not make that assumption based on just how his physical appearance is. So I think that, and he loves sports and he loves the office and he has all kinds of things that are, make him a really amazing, unique individual. But I think that there are assumptions made if you don't spend the time to get to know to allow him to have his voice. So that means longer appointments, longer discussions, but all of these things are, really important to make sure that we are creating an environment where we're actually able to get to know our patients and their families in the right way. Yeah, so sorry guys, we're whipping through this enormous topic a lot, but we wanted to come back and talk about common threads in the long-term care population and in pediatric palliative care. We're all looking after a population who is often unable to consent for themselves, or there may be an assumption that they lack the capacity to consent, like there could be if you just walked by Travis's room, when in fact that may not be the case. And so I think that's incredibly important. Staffing concerns we've alluded to a lot. Poor working conditions, understaffed, lots of high turnover, inability to sort of feel like you've got the expertise, the training, and the education to provide the right care or the best care, because you're constantly just running the hamster treadmill of trying to fill in the next shift. We're seeing that in pediatrics. We're seeing that in long-term care. There is a feeling of lack of education in terms of, these are really complex patients, you're looking through a wide breadth of conditions. So the training is not always adequate, not enough experience. And we see this, in terms of community supports, in hospital supports, but also like in the education system that we're creating. There's not enough prevalence of training around ableism, ageism, disability in medical schools, in nursing schools, in our hospitals in terms of competencies and things that we need to keep up on all the time. So I think that there's a big role for improvement here, but we're seeing this across the board. And then disparities based on race, ethnicity, language, where you live, your gender, your sexual orientation, all of these, if you are someone who lives 3 hours away from a tertiary care center, you're not necessarily able to get the same supports as if you live in a big city. We're seeing this in many different facets. So there's a lot of problems that sort of transcend the entire palliative care realm. Sorry, Dr. Arya, I don't know if you have anything to add there.
Yeah, I don't think so. And I think we can just sort of wrap up, given that our time is coming to a close very shortly. So what are some solutions and what are some things which can actually improve, the long-term care system and more broadly, how we care for older adults who are living with a disability, and how can we also improve the care for children who are living with a disability? Well, number one, you kind of heard our message, increase funding for home care. I can tell you from my perspective, ideally in Canada, long-term care should not be a place, but it should be a verb. If you're receiving care, you should be able to receive that care regardless of your location and regardless of your postal code, regardless of your address or even your location within the healthcare system. Of course, from the long-term care perspective, as we talked about warehousing and having people living in like 200 or 300 bed long-term care homes, but it's not that congregate living should not exist. There are people who would benefit from and perhaps even need congregate living for sure, but we can have smaller group home models. We can provide older adults and older adults with disabilities more supportive housing. My colleague, Dr. Van Zanten, would definitely say that we need more residential pediatric hospices, and she spoke about respite. We already spoke about working conditions, making sure staff are all trained to provide the specialized care that people with disabilities, whether older or younger, they require. We didn't spend a lot of time on this, but of course, there's a lot of, in fact, billions of dollars of unpaid labor that goes into caregiving in Canada that supports and props up the healthcare system. And the majority of essential caregivers in Canada, a reminder, they're mostly women who are doing this work for free to actually care for people with disabilities. And of course, we need support from policymakers to ensure that the care that people receive is accountable, it's transparent, and ideally, we need services like palliative care, long-term care, pediatric palliative care to be included in some form of legislation to support it, which should have funding on an urgent timeline as well. So we have the Canada Health Act, which actually has a very narrow sort of coverage only for physician care and hospital care. But, of course, we've talked today about something much more broader: palliative care, long-term care, home care. Those things are actually not covered in the Canada Health Act, which has led to piecemeal coverage across the country, a lot of fragmentation, a lot of gaps in care. And in some cases, at least from the perspective of long-term care, a significant proportion of long-term care is delivered by for-profit companies as well. So there is a way forward here, and we need policymakers, governments to support change. And just in conclusion, our final slide is that, of course, we don't often think about this, but we should be thinking about palliative care from that lens of ableism and ageism, and think about palliative care as a disability justice issue. That's what it fundamentally is. Everyone we look after is living with a disability, and that is something we have to recognize, we have to think about, we have to discuss when there are teams, and when we're advocating for funding, we're advocating for resources, we have to take this into account, and we have to center the voices of people with disabilities when we're doing this advocacy as well. Palliative care is uniquely positioned to think about relief of suffering, and we're often on a daily basis thinking about pain relief and suffering, relief of suffering from anxiety or insomnia, helping people with psychosocial distress. But we need to think more about relief of suffering from forms of discrimination like ageism and ableism as well, and the systems that were created by people who actually were able-bodied, which have led to this current situation at this time. So our system is not designed fundamentally at the very root to care for our patients, unfortunately. But as healthcare providers, we can be advocates, and we can work together, whether it's at the level of the individual patient that we're trying to make their lives better, or whether it's at the organizational level, at the level of our local hospital, long-term care home, our hospice, pediatric hospice, or when we're talking to policymakers, politicians, when we're voting. All of those things, healthcare providers have a big duty to actually use their position to create change. So thank you very much on behalf of Dr. Van Zanten and I. Thank you very much for joining us for today's talk.
Thank you so much to both of you. Such an insightful, both sides, but they somehow, interlink. I'd like to thank everybody for attending the session today. We did love the interactivity and, how everything went down in the chat. So we were very mindful of that. And yeah, a recording of the session will be emailed to registrants within the next week. And thank you so much for your participation. Once again, Dr. Van Zanten, Dr. Arya, thank you so much for being with us today.